So in the next minutes, I'm going to talk about the role of data science in anesthesiology and intensive care. And let me begin with the futuristic outlook. A bit less than 10 years ago, the European Society of Intensive Care Medicine asked its experts to share their vision how intensive care will look like in 2050. In one of these publications, Gattinoni, Jean-Louis Vincent, and Salatsky say that our hospitals are going to be smaller, but the proportion of ICU beds will increase, and the hospital rooms will resemble much more hotel room than the current environment. If a patient becomes critically ill, hemodynamic parameters and microcirculation will be continuously detected by non-invasive sensors attached to the chest of the patients and the limbs. And also the bed will be able to move up and down to assess fluid responsiveness and hopefully pressure responsiveness as well. And these sensors are going to be connected to drug delivery pumps, creating so-called closed-loop systems. And these systems will allow the continuous management of vasopressor therapy, inotropic therapy, fluid management, and so on. Much fewer blood sampling will be necessary in these institutions, since most of the laboratory parameters are going to be detected non-invasively, and the already familiar, always flashing, beeping, and alarming monitors will disappear completely from the ICU. Instead, there will be one large monitor remaining off most of the time and switching on if the system detects danger, giving information to the healthcare professionals to evaluate. Also, all of the data of the patients will feed into a network clinical trials in order to enhance individualized patient management and also collaborative research work in the future. Patients entering the hospital and admitted to the wards will receive vaccines against multi-drug resistant pathogens, and they will spend most of the time not lying in bed, but maybe even walking in a park with the help of a robot. The incidence of endotracheal intubation and the duration of mechanical ventilation will significantly reduce due to non-invasive techniques, but if the patient requires it for a while, then a dedicated machine will perform it. And there will be still a lot of interventions and procedures in these hospitals, but the presence of surgeons will be limited due to the fact that most of these procedures will be performed or carried out by automated systems. I think of myself as an optimist, but given that we are in 2025 and we have only 25 years left, I think intensive care has still a long way to go. But I think this short summary gives us the description of the direction we are heading. So in order to understand the tools and the models we are going to talk about later, it's important to clarify some key definitions. So data science is a discipline concerned with the analysis and interpretation of data. When we talk about artificial intelligence, we are referring to systems that are intended to mimic the human intelligence. And an important subgroup of AI is machine learning. Actually, these models are trained based on large data sets in order to make predictions, classifications, clustering, and so. And even more advanced technology is deep learning, which consists of multiple neural network layers. And itself, artificial neural network is a model that is inspired by the functioning of human neurons. Here you can see the main types of machine learning. On the left, supervised learning. Here the point is that we have predefined predictors and predefined outcomes, and with the help of a large data set, we can train our data in order to make it able to do predictions based on new unseen data. On the other hand, on the right, as you can see, there is unsupervised machine learning. Here, these models are able to deal with large heterogeneous populations, and they can discover hidden patterns, and they can, for example, identify subphenotype for sepsis or so. And an even more advanced technology is deep learning. Actually, the structure of these models consists of similar layers as the neurons in the brain, and these are so-called nodes, and these nodes are actually connected to each other, and they receive information from one to the other when a certain threshold in quality and quantity of data is achieved. So it has been almost a cliche to say that data is the next oil, the next source of value in the future. And this is especially true in the case of intensive care, where if we think of our patients, all the general information, the diagnosis, interventions, imaging results, and all the monitoring and the results that, all the parameters that we are providing all the time, these can be a very important information. But in order to make this information valuable, we need to collect the data, store it, analyze it, and interpret it in the right manner. The so-called PDMS, or patient data management systems, are intended to fill this gap, and they are able to perform real-time monitoring, medical history and treatment tracking, and also the data collection and analysis. So actually, this PDMS is a link between our monitoring system and the hospital information system. With the rapid progress of AI and data science, it's becoming obvious that in the next years we are going to meet these tools not only in our everyday but also in our professional life. And as you can see, in 2015 there were hardly any tools which were based on machine learning and were approved in Europe or the US. But in a few years, the number of them increased to 100. And before this presentation, I checked the website of the FDA, and there are already only in the US more than 1,200 tools approved. These are mainly related to radiology, but also on the field of neurology and cardiovascular care, and some in anesthesia also can be found. So these tools have several limitations, even legal, ethical, medical, and data privacy limitations, and it will raise a lot of questions, that's for sure. For that reason, the European Medicines Agency has created a work plan for the next years to create a regulatory network of these problems and questions. So now, after this general introduction, let's see specific examples where and how data science can play a role in our profession. If you think of conventional ventilation, what happens is that we set the parameters of the ventilator, and we check the reaction of the patient. We do physiological measurements, and if we can see undesirable alterations, then we revise our decisions. This is complex, and this requires expertise and also the continuous presence of healthcare professionals. But to be honest, we are not all the time at the bedside. And then these models, structure will be an open, uncontrolled system. On the other hand, in automated modes, there are given variables that can be set to target values, and then in an adaptive and automated way, the system can itself change the breath by breath or even within breath the settings. Of course, these systems also have limitations, such as if we choose an incorrect minute ventilation, it can lead to hypercapnia or respiratory acidosis as well. So in this chronological graph, you can see the development of these automated ventilation modes in the last 30 years. We wouldn't go into too much into detail, but the point here is that initially there were only one or two, a few parameters that were able to be changed in these systems, and these algorithms already relate to the field of data science. But nowadays they are developing much more complicated systems where at the same time you can change, or not you, but the machine will change many of the parameters. These systems will require machine learning and deep learning for sure. Another important area is sepsis prediction and treatment, where intensive research is done. And there are existing models predicting the sepsis, and even a meta-analysis has been already done of their predictive performance. But I would highlight two of these studies. One is the real-time early warning score, which is a machine learning predictive model that was based on a mimic database. I will talk about this later. And they used routine laboratory and physiological parameters. And what they found is that septic shock was predictable more than 24 hours in advance. And currently this system is in clinical application in the Johns Hopkins Hospital. Another important publication is the artificial intelligence clinician, where they created machine learning decision support model. This was also based on the mimic data set. And this model was intended to optimize vasopressor and fluid therapy. And what they found during the validation is that the treatments differing from AI clinician recommendations influenced mortality in a dose-dependent manner. And currently, this system is under prospective clinical validation in the UK. Also, there is intensive research on the AKI prediction. So even for the perioperative period and even for intensive care settings, there have been multiple predictive models, and even their predictive performance have been analyzed in systematic reviews. And I would highlight that there is already an existing tool which can be used in any ICU setting where this already mentioned PDMS system exists. The point here is that it has 3 modules. It's able to do AKI staging real time. Also, it's able to do predictions 24 hours in advance for the risk of AKI. And also, it can give you guideline-based recommendations, for example, when to give diuretics or how to change possibly nephrotoxic drugs dose, and when to consult a nephrologist. Besides intensive care, even anesthesiology is an important field in terms of data science. There are so-called pharmacological models that can perform closed-loop anesthesia. The point here is that there are sensors that are connected to the drug delivery pumps, and so it allows to provide automatic and continuous vasopressor fluid management, the depth of anesthesia, neuromuscular blockage, and also analgesia. So currently, these systems are working isolatedly, but there are currently researches on working in these multiple input, multiple output systems, and these are very, very heterogeneous and very complex systems, and they should use also machine learning and deep learning to be effective. Next to pharmacological models, there are mechanical robots as well, such as the known Da Vinci and Kepler systems for intubation, and also Magellan system can perform peripheral nerve blocks. There are so-called cognitive robots, which are able to predict unwanted events in the future, or even risk stratification, and it can serve as a link between the patient's data and the hospital information system to collect and analyze the data of the patients. And now let me talk about briefly our research, which is the role of artificial intelligence in decision-making for extubation of mechanically ventilated patients. Actually, I got interested in this topic a few years ago during my residency when I saw that in different ICUs, in different settings, the decision on extubation and weaning varies a lot, not even among centers, but even within a center among physicians. And that was a bit weird for me, and I looked for guidelines and recommendations, and there are ones from France, from the US, from India, and several, but these are not consistent. And even if we check the European Society of Intensive Care Medicine's webpage, we can see that there is no gold standard method or no guideline how to wean and how to extubate a patient. There is one which is under development, so hopefully one day we will have one, but currently there is no guide when to extubate these patients. A few months ago, a large study was published, and they created a so-called systematic evidence map, where they identified 155 predictors that were used to predict extubation success or weaning success. And this suggested me that actually we have a lot of parameters that can be useful, but we are not able to integrate all of these parameters and all of these data, and that's where data science comes into the picture. To create machine learning models, of course, we need first a very good structured data set. That would take years to collect the data for these modeling, but hopefully or already existing ICU data sets are accessible, and hopefully in the future we can use them to make these models as well. And why prediction of extubation success is important, and why is it programmatic in the ICU? So nearly every second ICU patient is mechanically ventilated. Despite protocols, the reincubation rate remains quite high, between 10 and 20%, and the practice of extubation varies widely among centers and physicians as well, as I told you. But what do we know so far? We know that there is evidence that failed or delayed extubation might cause complications and affect outcomes, such as length of stay in ICU or mortality. It has also already been shown, as I showed you, that machine learning can predict outcomes. And our aim is to find the optimal timing of extubation and develop decision support systems, and also in the future to have consistent guidelines. So our research plan consists of several stepside studies. First, we are investigating the accuracy of already existing machine learning models in predicting extubation success. This is a systematic review and meta-analysis, and our aim is to identify the best performing models and the predictors. And based on the findings of this study, we are planning to develop and validate a clinically applicable machine learning model. The point here would be to have predictors that can be accessible in any ICU setting. And I would be very happy if in a third stage we can validate it in a prospective way. We conducted a systematic search and we had more than 13,000 results, and finally we had 26 eligible articles. And here you can see our main results. On the left, the eligible articles and the best performing machine learning models with their sample size. And the outcome measure here was area under the curve, which is the most frequently presented outcome measure in the diagnostic studies. And what we found is that the pooled AUC of the best performing models was 0.90. We also performed subgroup analysis, and what was interesting is that deep learning methods that are the most advanced technologies and the classical traditional machine learning models had similarly good predictive performance above 0.85. On the other hand, the most frequently presented clinical index, which is used in clinical practice, was the rapid shallow breathing, and the pooled AUC of this index was only 0.57. So building a machine learning model consists of several steps. First, we need to start with idea conceptualization. That means we need to define the predictors and outcomes we are interested in. In a second step, we need to collect the data. As I told you, we are planning to use already well-structured, accessible ICU data sets. Third step is tool identification, where we need to define the programming language and the machine learning type we are using. Here, it's important again to talk about supervised learning, which is an algorithm that applies predefined predictors and outcomes, and with the help of large labeled data, we can train our model to make it able to do prediction based on new unseen data. Then we need to filter our data, clean it to identify missing values, outliers, inconsistencies, and also we can now build our model and we should evaluate its performance. So what we have so far is a programming code. We need deployment, we need to apply it in a real-world environment, such as an application or an online platform, and we need to share it with users, with clinicians, to rely on their opinion to improve our model further and further. So in summary, the big data produced in critical care is a huge opportunity for us, and we have to facilitate the communication between clinicians and data scientists, because the technology is already given. It has been here for 30, 50 years, I don't know. But we clinicians are the ones who are able to ask the relevant questions. And it's also very important to have critical thinking and to know the limitations of these tools that are going to be used in the future. And finally, I truly believe that, as with any other technological innovation, if we are using AI with the right purpose for the right intention, then we are on the good path. Thank you very much for your attention.